Is Dr. Guy Mintz, and I am the co-chair of programming for the Lipid Panel, working alongside Dr. Ann Goldberg and Brittany Thompson. The Lipid Panel was conceived to be a lipid clinic conference in a national scale. For those of us lucky to have enough of in-house experts that we have a local lipid clinic, this conference is a great way to debrief and discuss cases that we all see in our daily practices, look at new diagnostic approaches and how to interpret these clinical findings, generate therapeutic strategies, and come together as colleagues. For the rest of us who feel like we are on lipid islands, conferences like this remind you that you're not alone. If you have any cases that you would like to present at future conferences, please email Brittany Thompson at bthompson@lipid.org with all of your suggestions. In this series, we review common presentations of rare diseases, atypical presentations of common conditions, sometimes even common presentations of common conditions, and we will try to cover as many clinical topics that every lipid specialist needs to know. The series is meant to be a monthly coming together of rising stars like our MNLA lipid scholars or various fellows in different specialties and early career lipid specialists with more experienced colleagues. Look for our schedule posting for the final Tuesday of every month and join us. This evening, I am joined by a superb panel, Dr. Dan Soffer, who's the current president of the National Lipid Association and who developed the lipid panel, is our moderator this evening. This will be Dan's swan song as he's transitioning from co-chairman of the lipid panel to all the various aspects of being president of the National Lipid Association. We have with us Dr. Garshick, who's an assistant professor of medicine and dermatology at NYU Langone Health. He graduated from Tufts University School of Medicine. He completed internal medicine residency at Columbia and cardiology fellowship and research fellowship, as well as a master's program in clinical investigation at NYU Health. Dr. Garshick's clinical and research interests include exploring mechanisms of therapeutics to treat cardiovascular disease in patients with immune-mediated inflammatory diseases. He runs the cardio rheumatology clinic at NYU Langone Health in New York, and we're excited to hear his presentation on inflammatory disease. We also have with us Dr. Willibroad Maimo, who's a board-certified internist and cardiology fellow at the Emory University School of Medicine. He has a strong passion for primary and secondary prevention of cardiovascular disease with a focus on risk stratification and cardioembolic disease. Dr. Maimo will be presenting our case this evening. He's been involved in the National Lipid Association Lipid Scholars Program and will be completing his fellowship later this year. We're also joined by Dr. Ann Goldberg, our co-chairman of the lipid panel and professor of medicine at the Washington University School of Medicine in St. Louis. So it's my pleasure to present the lipid panel this evening. And Dr. Maimo, you can present your case, and I look forward to our discussion this evening.
Dr. Mintz, thank you very much for that introduction. Good evening, everyone. And I am really honored to present the case for today's lipid panel. And as we know, it is going to be focused on inflammatory diseases. The case we're going to discuss today will be on a patient with a chronic inflammatory condition. So to start off, this is a 60-year-old male who presents to rheumatology clinic for evaluation. He doesn't really have any acute complaints. He feels fine. He's relatively fit, exercises frequently. And really, in essence, he looks like a healthy 60-year-old gentleman. Of note in his medical history is that he has a history of high blood pressure. As you can see, his blood pressure is about 146/80, and he's currently just on lisinopril.
Actually,
Dr. Maimo,
up to you for a second. Thank you. Yeah, we couldn't see the slides, and we want to be able to look at the data as we go. I also want to warn you that I am prone to interrupt at any time to ask lots of questions along the way. So I should have warned you in advance.
Okay, you can't see the slides. I'm sorry. Let me.
We can now. We can now. Yeah.
You can see the slides again?
Yep. And
Okay.
it's a great time to actually just stop the case for a second, because before you already told us the punchline that this person has chronic inflammatory disease. But before we even get to that, it seems to me that there are some key elements that are already brought out in this very simplistic presentation of something that we see on a regular basis. So obviously we've invited Michael to be here tonight to talk about the impact of inflammatory disease. But even if we don't know whether or not if an inflammatory disease is present, we already have some features that make me think about the cardiovascular risk of this person. And Will, I know you're finishing up your fellowship, so you're used to seeing just like the sickest of the sick in the hospital with all the worst complications. But this is the kind of case that we see on a regular basis in regular clinic. Patients who come in, they seem fine, they take fairly good care of themselves. They have some features that sort of raise the specter of concern, not the least of which is just being 60. And you have to start thinking about the risk right off the bat. And so Will, I'm going to put you on the spot first. So you're presenting the case, and I didn't give you any warning about this. So if you want to punt it to Michael or me or Guy, feel free to do so. But how do you see a guy like this and think to yourself, oh, 60 years old, high blood pressure, taking one drug to control his blood pressure. He smoked a few years, but he's not smoking anymore. Do you see him as having significant cardiovascular risk, or just a normal guy?
Well, this sounds like a normal guy to me. I mean, I'm sure, if I were to dig a little bit more, I would find areas where I think I can identify more risk factors, but just the presentation right now makes me think this is an otherwise healthy gentleman with just one medical problem.
So is your feeling that, as long as he doesn't have terribly controlled risk factors, there's not that much to worry about him? Are you comfortable if he just does the usual, follows the basic recommendations for care, the national guidelines for primary prevention? Is that sort of your thought process on how to manage this kind of patient?
Well, I think at this point in time, he has definitely rooms for improvement. At least his blood pressure doesn't seem well controlled. So I think I would be a bit aggressive about that. And the fact that he's a previous smoker, I would think about other medications, especially, probably that's another area where he's had some chronic inflammation from smoking, and he might benefit from a statin. But, I think there are things we can do to optimize his cardiovascular risk from a primary prevention standpoint. And, it would be good to, obviously, if this was my patient, I would talk about, things like diet, things like exercise, to try to get a sense of where he is in the spectrum of just general prevention as a whole.
Yeah. Yeah. I'm sure I'm torturing you with this because there's not much data being shown. But, this strikes home for me because he's, I'm in this same demographic, and I see this, and a lot of my friends are in this demographic, and we're all sort of walking around feeling like we're okay as long as we don't have like some major feature of concern. But, he runs on a regular basis, and I do think about some things about, urgent and imminent cardiovascular risk with him. So I have a little bit of concerns. The smoking history and the high blood pressure. All right, so I'll stop interrupting, at least until the next time I interrupt. And I don't know if Guy or Michael, you wanted to throw in your 2 cents already, or is it too soon to start chiming in?
No, I mean, I would just say, of course, this is one blood pressure reading, but there's certainly plenty of room to improve his, lisinopril dosage, and he's exercising already. So when he stops smoking already, that's positive. So we'll have to see what his other risk factors are, and certainly his lipid profile.
Yeah, I tell patients like this, you're fundamentally healthy. We want to keep you healthy for the next 10 years or even 30 years.
Thank you.
And so, and so, when I see these folks, I mean, you can, just by the age, gender, and the blood pressure alone, forget about the smoking, you can almost guarantee his risk is going to be over 5%, almost regardless of the lipids. So it's kind of unfair, but that's why I have the phrase that I do, because I say you can't make someone feel better if they already feel good, but you can keep them feeling good for a long time.
Yeah, I agree. All right, Will, I'll turn it back to you.
Okay. Sorry. Where was I? I said it was a former smoker.
Yeah, I think we shared all. I think you're ready to move to the next part of this.
Okay. Well, on further taking of history, he tells you, at least you know, that he has a history of psoriasis, which was diagnosed at the age of 45 years old, so about 15 years ago. Previously involved an extensive amount of his body surface area, his arms, his elbows, his shin, and it covered about more than 10% of his body surface. He was started on a biologic therapy, and that seemed to bring it under significant control.
All right, so before we even jump on with any more details, so now we've learned a little bit more about him and his medical status. Obviously, there's a lot of attention to his skin at this point, and I'll tell you that at my institution, I know Michael works with the colleagues from my group doing some research, but in my institution, this is exactly the kind of patient that I get a lot of referrals from our dermatology group. They have a strong interest in the impact of psoriasis and cardiometabolic risk, and they rely on our group as their as a partner in the care. And even before I knew that this patient had psoriasis, I was already looking at a 60-year-old with some metabolic features and risk factors for cardiovascular disease, and I was already thinking about some different things that I could do to assess his risk and optimize his risk as well. Now I learned that he has psoriasis, and there's a lot of pressure from my psoriasis team to pay attention to this guy and do as much as we need. So, Michael, is this the kind of, I guess you do it all yourself. You work with your dermatology team. You're not actually treating the psoriasis, the skin conditions, right? You're diving into the cardiometabolic derangements that these patients have. Isn't that right?
Right. We act as a prevention center, similar to you. And so I would say, Dan, that you're in the upper 0.1% in terms of your referrals from your dermatology group for these patients, but you're also at an institution that's really had a defining history in linking these two, psoriasis and heart disease, but really across the country. And we've done survey studies, and people in your institution have done national survey studies showing that as a whole, we do a poor job of identifying cardiovascular risk in patients with any immune condition, but in this case, psoriasis.
And is there one immune inflammatory disease that is sort of worse than other autoimmune inflammatory diseases? Should we think of psoriasis as sort of the prototype, or is it?
Yeah, psoriasis. So, and to get to your question, I don't treat psoriatic disease. Yeah, I just treat the kind of cardiometabolic issues that arise, that coexist with it. I would say lupus is probably by far and away the biggest cardiovascular risk enhancing condition. Although it's technically not in the ACC/AHA, at least the old 2018 guidelines. But we say lupus is anywhere between 2 to 8-fold higher. It's a pretty wide distribution. I'd say it's probably more in the 2-fold range for cardiovascular issues. And then maybe RA a little bit more, but there's a lot of age issues with RA, because generally these patients with RA get it at an older age. Get RA at an older age. And then psoriasis. So psoriasis and RA, we say about a 50% higher risk overall. And we kind of lump ankylosing spondylitis in there, although that's a less common condition, so it's harder to study.
Yeah, I don't get the same number of referrals from our rheumatology division as I do from dermatology, I think, for the reasons you pointed out. But I do have a chance to speak with our rheumatologists periodically, and I try to whisper in their ear, hey, don't forget about the cardiometabolic risks that these patients have, and really pay attention to that. But again, we're not given the data yet on this patient's metabolic status, but we are given some key features in his cardiovascular risk. And hearing that there's psoriasis on top of some other risk factors, I have to tell you, like, if this patient shows up in my office, even before I start diving into their glycemic control, the presence or absence of fatty liver that's probably there, and the lipid derangements that may coexist, I also really want to clarify their short-term risk with imaging. And frankly, I would have probably gone there even without the presence of psoriasis. And so taking off your inflammatory disease goggles for a second, even if this same individual doesn't have autoimmune inflammatory disease, are you thinking along the same lines when you see a 60-year-old with hypertension who used to smoke, whether or not you're going to do imaging to help evaluate his risk?
Is that to me or anybody in the panel, since it's not inflammatory? But from my end, yes. I think even with, that's what we're doing a lot of times in this field, is just we say the no-brainer, which is identify and treat the traditional risk factors. And so, as you said, even without the psoriasis, we know he has hypertension, he's slightly older, and he is male and a prior smoker. So you can your pretest probability is already up to begin with. So personalizing what you want to do with some sort of imaging, I think, is a really nice approach. And then the inflammatory condition on top of that only heightens your pretest probability and your desire to potentially risk stratify him. It also depends what his wishes are in terms of treatment, and if you can do treatment without any imaging.
So Will, that's sort of what I was getting at was, and I set you up because I said, you probably think of this guy as probably just a normal guy. And the problem is that the normal features of having high blood pressure and having previously smoked, tell me that he either has, significant cardiovascular disease that's going to cause a problem in the next decade, or it's not. And while I applaud the authors of the guidelines and some really great scientists who put together things like risk calculators to help us determine how to treat our patients, it doesn't really tell us what the outcome of our patients are going to be. And so I'm very liberal with imaging as a tool in anyone who's in this kind of risk category, at sort of low to moderate risk category. And of course, we can't define it better because we're missing some data still, but very, very quick to use atherosclerosis imaging as a really key tool in helping to determine whether or not this person has atherosclerosis. And it's because I see the world through atherosclerosis lens, and I know that what he's coming to see me for is treatment of atherosclerosis. And so I always want to look for atherosclerosis when I'm asked to see somebody where I can make a difference in that disease. So I've already in my head ordered a coronary calcium score on this patient, even before I heard he had psoriasis.
So if I may ask this, let's say, for instance, you start talking to the patient, and let's say he's already on the statin. Just would it change your decision to get imaging in that case, or would you still proceed with imaging? The reason I ask is I don't know how it's going to affect your management if he's on some sort of statin.
I'm supposed to be the moderator in this case, so I'm going to punt that one to Michael first, see if he has an answer for that. But then I'll give you my answer. That's a great question, though, Will. I like that.
So yeah, it is a good question. It's a fair point, because I think in terms of the statin initiation question, you don't want to appear biased and give statins to all these patients, especially when they're being referred from your rheumatology and the dermatology colleagues, because then you lose the nuance and they say, well, what am I sending you for if you just start every single patient on a statin? But I think in seeing this patient, when regardless of the psoriasis, you think they're higher risk, you add a risk enhancing condition on top of that, and one with severe psoriasis with that 10% body surface area, the need for a biologic. And so where I tend to use the calcium score in these patients is potentially aggressiveness of therapy, although I do think there is a benefit if you can to get the LDL very low, but also with the antiplatelet consideration. So of course you want to make sure these patients, if they have coexisting psoriatic arthritis, are not taking chronic NSAIDs. Most aren't anymore, but that's another reason to get the calcium score, because then if they have a huge plaque burden, you feel even better about that. It could potentially benefit. But then this is where some of my translational work I fall back on, even though it's a little dangerous, but we see a consistent platelet aggregation signature in these patients. And so in these, I find the calcium score particularly useful. In addition to other blood work, which we'll probably talk about soon, to try to get an antiplatelet therapy for these folks.
That's a much better answer than what I was thinking. And I definitely, if I forget to ask you, Michael, I definitely want to circle back to the antiplatelet issue. But Will, I think your question was really useful, because the concept of using a coronary calcium score only as a statin or no statin decision tool, I think is by now inadequate as the only tool the only reason to do the coronary calcium score. So I think knowing somebody's atherosclerosis burden gives me a lot more information than not knowing their atherosclerosis burden, even if I already know that they have good indications to take medicine. And so I think in the clinic, I have a very low threshold for using the coronary calcium score, as long as I don't have some other imaging modality there where they've already, your patients are primarily already going to have caths and all kinds of other imaging, but in the primary prevention world, most don't have those kinds of things. And so having another tool to assess atherosclerosis burden is very helpful. So we'll definitely get back to the platelet issue, but it definitely answers that question really well. So yeah, jump ahead and give us some of the details.
Sorry, but can you guys see the slides?
Yes, thank you.
Okay. For some reason it's not affecting. So we get a lipid panel, and shown below here is what his lipid panel is. We have a total cholesterol of 208 milligrams per deciliter and HDL cholesterol of 46. Okay, thank God. An LDL cholesterol of 133 milligrams per deciliters and triglycerides of 160 milligrams per deciliters. Hemoglobin A1C was also obtained, which is within normal limits of 5.4.
Okay. Believe it or not, Will, I don't have any questions.
Okay. Given his history of chronic inflammation or psoriasis, we proceed to get a high sensitive C-reactive protein on the lipoprotein A, and we see that even though the high sensitive C-reactive protein is normal, he has an elevated lipoprotein A of 178 milligrams per deciliters.
So that's pretty high.
That is very
Maybe go back to that last slide. So we'll talk about the results here in a minute, but so the lipid profile looks mostly normal, like what we see all day long, every day in all of our patients. Nothing really jumps out as terribly abnormal, other than it's the kind of lipid panel that you see in people who don't have heart disease, and it's the kind of lipid panel that you see in people who do have heart disease. So it doesn't tell me one way or the other whether the patient has heart disease, of course. Couple pieces missing from it, like the non-HDL cholesterol. We're not told how the LDL cholesterol was calculated, but probably not critical here. And notably, we don't have an ApoB level, which might give us a little bit more information about the atherogenic potential from this lipid profile. So that's something I typically use as part of my initial evaluation. But Michael, C-reactive protein, I know that's a useful inflammatory marker. Should we be, is that adequate in terms of getting a sense of like the degree of inflammation, or should we be doing other types of blood tests to help get a sense of how much inflammation is going on?
Right. In terms of on the market right now, what's available in your clinical laboratory, I don't believe there's much else besides a high sensitivity CRP. There's been a lot of research metrics about other inflammatory biomarkers or other inflammatory circulating biomarkers. In terms of clinically, HSCRP, and you could argue maybe an Lp(a) in terms of inflammatory biomarker as well. But interestingly, if you take 1,000 psoriasis patients and look at the relationship between psoriasis skin severity and CRP, you'll see a relationship. But on an individual patient level, it's highly inaccurate, meaning it's not a great metric of psoriatic skin activity. And it's not surprising that it's low when someone has a lot of skin involvement, or it's high when someone's skin involvement is clear. We don't use it as a biomarker of activity of the psoriatic disease. It does tend to be higher in patients with psoriatic arthritis. And the same way we think of CRP, and actually it's used in the calculation of RA activity, we don't use that in psoriasis at all. So the rheumatologist will check it for PSA. The dermatologist won't check it for, PSA for psoriatic arthritis. The dermatologist won't check it for psoriasis. But I do tend to check it in patients with psoriasis for risk stratification, although you could argue that there could be some central drivers that are not as applicable to the general population.
And Dan, I just like to point out, if you took this average looking patient and you put him in the 10-year ACCA AHA risk calculator, it'd come out to be about 14% 10-year ASCVD risk, which would give him intermediate risk. He has a risk enhancing feature with an elevated lipoprotein A greater than 125. This is milligrams per deciliter, so he's certainly over 50 milligrams per deciliter. So really, he's a high risk patient in terms of his LPA and his 10-year ASCVD risk score without even looking at the calcium score.
Yeah, and that was sort of my point. Even before we had the lipid profile, he was already looking like he had some features of concern from the very beginning. That's a very high lipoprotein a.
Yeah, and I think.
Do you think it has additional value in assessing this person's risk, knowing how much psoriasis he has and all these other features?
Yes. In fact, I'm going to be on the abstract that we're submitting to the ACC. A close colleague and friend of mine who does a similar thing to like me in Boston led it, showing how Lp(a) can be synergistic in cardiovascular risk in these patients with immune-mediated conditions. So I do think it adds value beyond just the knowing what we already know.
Michael, just another question. As we look at these patients' risk profile, where would patients with inflammatory bowel disease fit into your mantra with regard to risk?
Right. There was a nice JACC review article a few years ago that went through the literature, and I'm not sure a heck of a lot has changed since then. I think in general, we do consider it a cardiovascular risk enhancing condition, although I do find the literature a little less convincing than in other immune-mediated diseases. Although certainly a lot of these, there is a strong TNF-alpha signature in inflammatory bowel disease. It's treated that way. So I do think there is a connection. But I think there are certainly, in some of the untreated ones, there are also malnutrition issues that may make them underweight, not overweight. So I think it's a complex issue. But if you talk to the GI docs, they do think there's a connection, and I do risk stratify them with calcium scores for the right age, similarly.
Great, thank you.
So I know you did some fancy tests beyond this also, since we showed the next slide inadvertently. So why don't you move on to the next picture? So you did a CTA on this patient. Did you go straight to CTA? Did you bypass coronary calcium score?
Well, this patient is a bit interesting. This is a patient of mine. I just saw him about 2 months ago or a month and a half ago. We have this program with our dermatology colleagues where we're trying to identify risk in the dermatology clinic and then route them into getting risk stratification. So this patient, just based on the smoking and the blood pressure, was already identified. Forget about, we all pointed out, forget about the lipids. You can kind of read the tea leaves. So he entered a research protocol of mine that included a CCTA as part of the research protocol, and we felt that it'd be good not just for research, but also he's an underserved individual, and we felt that he calcium scores cost money, and this doesn't. So we obviously didn't say it that way, but I think the fact is there are multiple reasons that we were hoping to help him, and so through a research protocol, we were able to get a CCTA. And then once we got the results, we routed them into my clinic within a few days. But I'm sure but I would probably do a calcium score in these patients when they come into my office normally.
But pretend no one's listening. You're allowed to say it out loud. Do you prefer to get a CCTA if you can, as opposed to a calcium score?
Right. I do enjoy the data more. There's been all sorts of studies about the higher prevalence of soft calcium as opposed to calcium in these immune-mediated diseases. And, colleagues of yours have done a lot of work on kind of more dangerous soft plaque. I will say in my own cohort, I've yet to see soft plaque without some sort of calcific plaque in general, although it does, we all know it can happen. So I think it depends on the patient's symptomatology. But I generally won't. If the calcium score is medically the way to go, then I'll suggest that for risk stratification over saying, oh, you should get the CCTA because it's a better test, even if it's more expensive and more radiation also. So I think there's and it's an IV contrast. So I think I do stay with calcium scores if it's the right test for the patient.
So this guy really rang the bell on his calcium score. Is there something about psoriasis in particular? My patients ask me this all the time. Is the plaque that they're seeing on the CAT scan the same as the plaque that's on the skin?
I mean, there is, I would say I think we're still getting the data because a lot of it's been generated from one group in general that I'm most familiar with. Although there are groups in other parts of the world trying to study this condition as well with other CCTA cohorts in Spain. I think there may be a higher prevalence of soft plaque and more dangerous plaque, but I still treat these the same way in terms of what the calcium score means, if there's obstructive disease, what it means. And I think most of us would. If you saw a high calcium burden, you'd be very aggressive with LDL lowering. You'd be, you'd consider antiplatelet therapy if there was the risk benefit profile was appropriate. So I don't necessarily do procedures on these patients as opposed to any other medically indicated reason for a procedure.
And you mentioned aspirin there. I've looked at some of the data on how we should select aspirin for our patients based upon coronary calcium scoring. And I think probably like you and others that you sort of use this arbitrary, it's not less than arbitrary number of a calcium score of 100 or greater to indicate a need for aspirin. But you suggested that maybe the platelet aggregation phenomena that is present in psoriasis might make you lean more towards using aspirin at maybe a lower threshold.
I still use the calcium score of 100 because as excited as I get about my translational data, it's only translational data and it's great for hypothesis generation, but I think we rely on larger data sets, and even then clinical trials, which obviously there haven't been any on this question, but I still think you have to be somewhat mainstream. But I think that when we think about where the equipoise lies, when you start connecting a lot of dots together, then I think that it becomes beneficial in the higher cardiovascular risk individual, and we're kind of getting at multiple ways of saying this patient has high cardiovascular risk.
Michael, do you think that the cardiovascular disease is more due to the super high LPA or the psoriasis, or LPA is magnifying psoriasis, or vice versa?
Yes.
All of the above.
I think it's all the above. Again, I think there's a synergism that develops between all these, and there are some papers under review. There's other papers reviewed that really talk about this, and I think that there is a synergistic effect of the traditional risk factors with the independent contribution of psoriasis, but it also feeds back on itself. If you take a patient with psoriasis and you give them a hypocaloric diet, doesn't matter what type of diet, and they lose weight, the psoriasis improves. So that's why I say yes, because I think it's all connected.
Well, I know you're going to tell us a bit more about psoriasis and coronary disease. But, before we had the calcium score in front of us in the CCTA, it was quite possible that this patient was going to have a 0 calcium score. We didn't know until we knew. And Will, you were thinking of this guy as being pretty normal. We learned some new data on him. Do you think if his calcium score was 0 and his calculated risk was 14%, as Guy calculated, that you'd be inclined to want to treat him with statins or let him be, Will?
I mean, with that Lp(a), I would treat him. The reason being that I want to try to I know that statins don't have an effect on Lp(a), but it just puts him at a higher risk group, and so bringing his residual cardiovascular risk as low as possible would be my goal. Even though it does not affect the Lp(a), but I think that just when you look at the risk profile, it's and if you think about it, the studies did not really look into Lp(a), calcium. I don't know. The long story is that I would try to optimize his cardiovascular risk to the best of my abilities because of his Lp(a), which puts him at an increased risk for cardiovascular disease.
Yeah, I think that's pretty reasonable. He looked like he had some features that made you nervous in the first place. Even if his calcium score was 0, you still wouldn't feel that great about it. Maybe if he pushes back and says, "Doc, my calcium score is 0, I really don't want to take a statin," you can at least breathe a little bit of sigh of relief knowing that you have a good, probably of all the risk predictors that we looked at in this patient, maybe the best risk predictor is the calcium score still compared to any of the biomarkers that we have. But nonetheless, this patient doesn't have a calcium score of 0, has a calcium score of 1500 and obstructive disease. And so, Michael, I'm going to turn it over to you. I think you were going to tell us a little bit about how all these things interplay and why we think about inflammatory disease and coronary artery disease.
Right. Well, I was going to talk about the Lp(a). I don't know if you want to save that for a later time or
No, go ahead. Go for
it. We had some earlier work in my lab showing the higher Lp(a) signature in psoriasis, and I got very excited because it made sense. There is, interestingly, in psoriasis, even though IL-6 is not a central disease driver of psoriatic skin and joint disease, in fact, if you treat psoriasis patients or psoriasis mice with an IL-6 inhibitor, they get a little worse or they stay about the same. But in my cohorts, other cohorts as well, you see this consistent IL-6 signature. So I think about psoriasis as a series of causal pathways and then these bystander pathways. And so and I can talk about that a little later, but in terms of so I think IL-6 is one of these things where it's not causal, but it's certainly higher and being generated from all the inflammatory processes in the skin. And there's an IL-6 promoter region on the Lp(a) gene. And so we had theories that Lp(a) would be higher in psoriasis, but it didn't really pan out in our study and others as well. Although there has been some work where in the NIH's group, NIHL's group, showing that oxidized Lp(a) may be higher, oxidized HDL may be higher. And he had some earlier publications as well showing that Lp(a) was higher in psoriasis, but I'm not really sure that panned out. But we do think there is a connection between IL-6 and Lp(a) in general, and inflammation in Lp(a). So I guess this is one slide or this one review that I put together a few years ago, showing the dose response relationship between those with a history of psoriatic disease and the traditional cardiometabolic comorbidities, and just showing how really they're all increased in psoriasis, even smoking, which is quite interesting. And so this is one of the reasons that we say it's very tough to separate out the cardiometabolic issues with the inflammation because of how interrelated they are. And I sometimes argue it doesn't matter. You're going to treat the diabetes, the metabolic syndrome, the obesity, the hypertension, whether they have psoriasis or not. But what I do argue for is perhaps more aggressive management of these conditions and more aggressive identification. I think that's really where the gap is.
So that's the crux, really. So when the dermatologist in my institution sends me patients, I do the full risk assessment. And then wherever I end up, I sort of tag on, and they have psoriasis.
Right.
And whatever it is I thought I was going to be doing, I just tweak it a little bit more. That's as scientific as I get. Do you think that that's the right approach?
Yes, I think you're in a very special place where I think that the identification has already been done for you, but it's actually shocking. You know, there's actually one of the best, my favorite studies was a study from, gosh, like 2012, where they looked at all these patients entering into a psoriasis clinical trial of biologics, a medication called ustekinumab, which is an IL-12/23 inhibitor. And all they did was just look at the patient, what are the cardiometabolic issues of the patients out enrolling and how aggressive they were being treated. And 2/3, I think actually all of them had at least one cardiometabolic condition. But the point of this is only 1/3, or I think, no, sorry, only 8% had all of the risk factors appropriately managed. And those were blood pressure, cholesterol, hemoglobin A1C. Isn't that crazy? So patients going into a clinical trial you think are more aggressively managed, have better outcomes, no matter if they're in the placebo or the treatment group, but only 8% had all three metrics appropriately managed in terms of blood pressures under 100, LDL 130, LDLs under 100, hemoglobin A1C under 7. And I don't think that's changed much in the past 11 years. So really it's kind of a lot of the field has gone into implementation science, trying to identify these patients and just route them in. And the way we phrase it is that these patients are being seen their dermatologists, their rheumatologists. They're already seeing providers every few months, and they think they're healthy. And so why do I have to go to my primary care doctor? I don't really want to see a preventive cardiologist. I live someplace without preventive cardiologists because we're not that common. And so they're not seen for years by a primary care doctor or a cardiologist for that matter. So it's really getting the dermatologists and rheumatologists to identify who these patients are that are higher risk or who have high blood pressure, high cholesterol, diabetes, and route them into appropriate management clinics.
So I have a $64,000 question for you. Looking at this slide summary from your review, is it the psoriasis that's causing all these metabolic derangements, or do the metabolic derangements cause the psoriasis?
Right. There was something that was called the psoriatic march concept, which is kind of fallen by the wayside a bit, but it was out of psoriasis causes the cardiometabolic issues that causes the cardiovascular disease. And I think that's only partially true. I think there is certainly an independent contribution, but that was the way it was thought of about 11, 12 years ago. But I think it's all interrelated. I think my next slide shows it's just a cartoon summary, but I think it shows that it's very hard to separate out, but there is an independent association after you adjust for these cardiometabolic issues that I think still pans out. And there is a higher relative risk in the young. We say the relative risk is the highest, up to 3-fold higher in young patients with severe psoriasis. So I think the absolute risk is actually quite low in your 30s or 40s, no matter how bad your psoriasis is. So I think the point is that there is an independent contribution, but it's really heightened by these traditional variables.
Can you take us through this a little bit?
Sure. This was a summary figure from one of our publications a few years ago, just discussing how it's the clinical variables, whether it's insulin resistance, dyslipidemia, obesity, actually something that is now talked about more, but depression and stress is higher in these psoriatic individuals, and we felt strongly you should put that in. And then it leads to, obviously, independently into endothelial damage and atherosclerosis. But however, there's this whole contribution of pathophysiologic variables. Interestingly, in these psoriatic individuals, even when you control psoriatic disease, even when you take out the traditional risk factors, inflammasome signaling is actually the highest differentially expressed inflammatory process in the blood. And for those of you who are unfamiliar, inflammasome signaling cardiovascular disease is a very, very hot topic right now. And many times when people say inflammation, they inadvertently are thinking inflammasome signaling, and that's that IL-1 beta to IL-6 to CRP process that is being targeted by some of the anti-inflammatory clinical trials that were positive, or even potentially by colchicine. So this inflammasome signaling, the same pathway that's been successfully targeted in secondary prevention cardiovascular trials, actually the highest in psoriasis, which is quite interesting. So we think that's one of the reasons why I think there is an independent inflammatory contribution. But I talk about all this, and then, but I still do, when I see a patient in the office, I say, okay, you have psoriasis, but not every single psoriasis patient is dying the next day of cardiovascular disease. This is still many times an age-dependent process. That's why I say you're fundamentally healthy, but we want to keep you healthy for the next X, Y, and Z years.
So, Michael, would you consider colchicine for this particular patient with the high risk and coronary disease? I know the CRP was not 2.0 as the cutoff, but for this particular patient at this time.
Right. I'm going to make a plug. We just before this conference, we had our first annual cardiorheumatology case series. We had an international audience, and one of our cases we presented was a psoriasis individual who was triple vessel disease. It wasn't this patient, who was on Humira, methotrexate. CRP was like 1, and they're on aspirin and rosuvastatin. And the cardiologist managed them anacolchicine. And it was a lot of discussion around that. And I think it depends. So the discussion came, well, how well are you controlling disease? They had psoriatic arthritis as well. And this is a very long-winded answer, but I guess we have some time. And I don't know if anacolchicine is the right way to go, but I'll tell you how we came to that. So the question is really, do you have good disease control? And in the case of psoriatic arthritis, it's much harder to control many times than psoriasis. So we weren't quite clear. But then these patients on biologics weren't really included, or they weren't very highly represented in a lot of these colchicine clinical trials, which also didn't use CRP as an enrollment criteria. So I think if they're having aggressive disease and it's progressing on appropriate psoriasis and antiplatelet and lipid therapy, I think it's very reasonable. But I'm not sure I would go right off the bat, because many of these biologics are actually quite safe these days. But there was in some of the colchicine clinical trials some signal to harm, and I just don't think we have the data. So it's a hard sell, and there's a lot of polypharmacy involved. In this case, the Humira and the methotrexate were probably a little more immunosuppressive than IL-17A inhibitors. But the colchicine is added with these biologics routinely, but it's for other conditions, not for the prevention of atherosclerotic cardiovascular disease. But I don't think you'd be crazy to if you really wanted to.
Can I ask you to speculate a little bit that if the CERT trial were designed to incorporate inflammatory markers as an inclusion criteria, that would methotrexate have been helpful for those patients?
Didn't use the CRP, right? I don't know. Maybe. I mean, there is RA data that maybe methotrexate could be beneficial, but are you controlling disease? Are you're not. I think colchicine is a bit of an easier sell than methotrexate for a variety of reasons, at least for me in my mind. So I wouldn't know the answer to that potentially. But I think it is a different mechanism than inflammasome targeting. And so what we've seen with CANTOS and with the series of colchicine trials has been potentially more of an inflammasome signature. And also we do have IL-6 inhibitor clinical trials that are testing, we're going down that pathway right now. And we've had a whole host of anti-inflammatory trials that have been negative.
Fantastic.
In this patient, with the cardiac CTA showing what it showed, basically this is an asymptomatic patient who has not really had any major cardiovascular event. How aggressive would you be on lowering his cholesterol? Would you consider adding non-statin therapy, or would statin just be sufficient for you?
As aggressive as I could be. I don't see any downside to it. I doubt we'll ever get I can't recall off the top of my head what his follow-up lipid value is. But I think it's a no-brainer to get him on get his LDL as low as possible. And I doubt I would be able to get a PCSK9 inhibitor in him. But who knows, right? Maybe the lipid profile will be LB predominant, and he won't budge, and we can get it approved. But we'll see.
Yeah, unhesitatingly, I would, I always tell my patients it's going to be statin, then ezetimibe, then a PCSK9 inhibitor, plus or minus bempedoic acid at the end. And, and I'm not going to stop until the LDL cholesterol is somewhere between 25 and 50 milligrams per deciliter in a patient with this much plaque and disease, or until they can't afford or can't access the next medicine on the list. Right. And those are the options. And aspirin and blood pressure control and Obviously continue to encourage heart healthy diet and regular exercise, and make sure he doesn't go back to smoking.
And if I can ask you a question, have you ever backed off on lipid lowering therapy?
I have. You mean if I overshoot beyond 25 milligrams per deciliter?
If it's undetectable.
Yeah, I have. Yeah.
Okay.
I actually think that I don't feel strongly about it. If somebody says, no, I don't want to back off anything, I'm like, okay, I'm fine with that. I don't think that there's significant risks from that. But I do try to sort of titrate the dose into that range.
Right.
And I'm going to say something that may be a little bit heretical, which is that I don't think there's a necessity of using high intensity statin in every single patient with cardiovascular disease. I think there is a necessity to start with a statin, and there's probably a preference to using a high intensity statin in high risk patients. But I don't think that there's great, benefit to be gained from going from, 20 milligrams of rosuvastatin to 40 milligrams of rosuvastatin. You're more likely to harm the patient with side effects than enjoy that 6% additional LDL cholesterol lowering benefit. That's, to me, is meaningless in that context. And you need to sort of think about using other modalities in that range.
I agree.
And you're still shooting, for a target of less than 70 milligrams per deciliter in your high-risk patients with an option of 55, and if European guidelines, option of 40. And as I think Dan said, we're all pretty comfortable with seeing LDLs less than 30 milligrams per deciliter in these high-risk patients.
I agree.
Great. So, Guy, do you have any more questions for Michael while we have a spotlight on him?
I don't know, Michael, if you want to comment a little on the CANTOS trial in terms of benefit with canakinumab with reducing just the CRP and the interleukin-6 pathway.
Yeah, it was a positive trial. It took a lot of patients to show it. Not FDA approved. I think the company's going down a lung cancer reduction route. But I think as a proof of concept, it was an incredible clinical trial, because I do think, at least from the cardiologists I hung out with, we had a strong concept in involvement of the immune system in atherosclerosis, but I think people really didn't believe that targeting it reduced cardiovascular disease. So I think CANTOS really helped solidify that in many people's minds. And then when you follow that with Colcott, Ledoco, LOCO2, really, I think it's become forefront now and a hot topic, which is very, very exciting. So I think it's a proof of concept that was fantastic. I will say, we're recruiting for the IL-6 inhibitor version of this, which is in patients with CKD and cardiovascular disease and CRP elevations. We're giving an IL-6 inhibitor to reduce cardiovascular events. It's exciting to me that it's powered for renal outcomes as well. But I think it's immunosuppressant medication. So I think we do a lot of stuff to people to reduce cardiovascular disease, aggressive anticoagulants, now maybe aggressive anti-inflammatory. So in terms of the 6 medication that can potentially be harmful, it can be a tough conversation sometimes. So when I find colchicine a little bit easier in terms of the conversation for the prevention of cardiovascular disease in patients with normal renal function.
I think that's great. Thank you. I don't see any questions from the audience. So, Dan, I would like to thank you again for creating the Lipid panel. I think this is a great opportunity to discuss cases and topics like tonight's inflammatory disease topics we wouldn't necessarily see on a day-to-day basis. And I'd like to thank Michael and Will for presenting and Dan for moderating. And I invite everyone to email Brittany Thompson of any topics or cases that you'd like to hear more about. And thank you all for contributing. Appreciate it.
Thank you for the invitation.
Thank you all.
Thanks.